Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters, comprehensive medical program of the Islamic Medical Association. And we're coming to you today from the Islamic Medical Association conference at Wanderers. It's been an excellent program so far. We sort of halfway through the first day. We've had some fantastic speakers and some wonderful atmosphere. And one of our outstanding and standout speakers today was Professor Elna Mcintosh, a clinical sexologist.
Yes.
And you know, I'm always good at flattering the ladies, but really it was well deserved, Prof. And welcome, and thanks for agreeing to talk to us for a little while.
Thank you. And it's been a lovely day just being here and on Freedom Day.
Excellent,
You know?
excellent. So I thought we just asked Professor Mcintosh while we have taken an opportunity to do a little interview and ask a few questions about the area of expertise. And obviously, when you talk about sexologists, you know, some people shy away. You know, we're Muslims. We don't talk about sex. You know, sex is taboo. Or if we're talking about sex with somebody who's you're not married to, it's you know something not right about that. But obviously, from a clinical perspective, you deal with people who have problems in that area. Can you tell us some of the issues that you deal with that are common?
So a lot of the patients that I will see are referred usually from a gynecologist, or they self-refer because nowadays with Facebook, internet, people Google, they find. So I specialize in painful intercourse,
Right.
Dyspareunia, the medical name.
Okay.
But then there's a severe form which is vaginismus.
Okay.
And these are people in unconsummated marriages. The longest I've seen was 18 years unconsummated, and recently in this year, 22 years unconsummated.
Okay.
And I said, but why now? And she said, we didn't know there's a place we can go to. So what it says to us is people are shy, because the minute we say sex,
Yes.
people will laugh,
Yes.
snigger. But when it's actually a problem, they don't
Yes.
know how, there's stigma, there's shame,
Absolutely.
often shame. And
But something must be wrong with them
something must be wrong.
if they have a problem in that area.
And especially if it's sexual, because people think, but it's so simple, anybody can do it.
Sure.
And often in very religious, and this could be not Islamic, just it could be Catholic, it could be Greek Orthodox, could be very Afrikaans,
Yes.
where it's a lot of emphasis. It's almost like parents say, keep them ignorant, then they'll remain innocent.
Sure.
But in the Quran, I don't know the Quran well, but I do know that sex is
It's
praised.
mentioned, yeah,
There's
yeah.
beautiful things written about
Yes,
sexual
absolutely.
relationships.
So I think let me just unpack that a bit for some of our viewers. So you mentioned that this condition of dyspareunia or painful intercourse is a fairly common condition, and the most severe form is vaginismus, is where in fact couples are unable to have sex at
Yes.
all, and the marriage is never consummated, and often it's a silent thing. The couple will never talk about it. And the only visible feature may be that the couple is childless, but there are many reasons for that, obviously.
Yes.
So it's difficult to tease out what that reason for it for.
And so often that is why we will see them,
Yes.
because now I
The
call
family
it,
is putting pressure on them.
when are you
Where's
having
the
a
kids?
baby?
Yeah,
And so when it becomes baby making.
sure. And then, I mean, I think at the beginning, sometimes the partners are not sure whether the husband is to blame, the wife is to blame. As you mentioned, sometimes the wife says, you're too big for me. When it goes, I have pain. When the husband says, no, you're too stiff. There are a lot of different reasons, and it can seriously affect the marriage, obviously. I'm sure you've seen that.
Very, very seriously. So I work in a group practice, and we actually once a month we have a meeting, and we call it the pelvic pain meeting. And there's a group. I came back to South Africa in 1998, where people didn't know what I was talking about.
Right.
Because in America we had pelvic floor physios and we had
Kegels.
specialized Kegels, but we now have specialized physios that specifically work
Yes.
and help us, and they come to the meetings. Even Botox, believe it or not. You know,
Yes,
Botox,
yes.
I feel it's like Zambak. It gets used for everything
Yes.
nowadays, but we
But
use
this may be
as
a
an
good
extreme,
indication.
in
Yeah.
an extreme form. It's not the first resort, it's the last resort. But very often, you can't say it's psychological, but the fear will start. The
And
fear,
aggravates the issue.
and I can almost see it in their posture. You know, they very tight. They literally uptight.
Yes.
And
Now, what would you say is the commonest cause for it? Is there an underlying medical condition? Is it related to medication they may be taking? Is it related to a postural abnormality, or is it just sort of unknown etiology with multiple different aspects which we can't really tease out, or would you have any clue as to?
So all of the above and more.
Okay.
So that is why it's important. We call it a sexological or a sex history.
Okay.
We need to take a proper, because it's no good blaming everything
Sure.
on, go to a psychologist. Our first port of call would be the gynecologist or a urologist,
Right.
because often women have had bladder problems as a child.
Right.
So her pain almost started in her bladder.
Right.
And because she had invasive treatments, or
Yes.
so she
They develop a
anything
pelvic pain syndrome.
anything down there, and sometimes it can be posture as well. Little girls do lots of ballet, and you can't say all ballerinas, all
Yes.
gymnasts, all horse riders, but often they it could be a contributing factor. They've got very tight muscles,
Yes.
but there are women that have imperforated hymens.
Yes.
Or there's actually another medical problem. She has fused. We don't encourage women to take out a mirror and look at yourself.
Yes.
But we almost
Need to.
we need to, because as we
It's
know,
not a visible
everything-
area.
Yeah.
And obviously, your parents are not looking at it. Unless it's something which is visible during childhood, it may be missed, especially through your adolescent years, and nobody else is looking at it. And rightly so. So it's necessary to look at it yourself.
And then if we just look what's happening in the media, there's a lot reported on violent rapes. There's movies with violent scenes. So a young woman can take almost vicarious trauma that she almost think this happened to her.
Yes.
And then we live in a country of violence, and a lot of women are raped,
Right.
or have
So there may have been sexual abuse during
abused.
childhood. And
So
forth
it's
and
important that we look, before we just say this is a medical problem, psychological, but it is quite an overlap.
Yes.
And but when they phone me and they tell me we did it, that
They're
is
so happy.
that is like a gold medal at the Olympics.
Yes. I'm sure
because
the rewards, obviously, for
The
you and the
reward-
patient
yeah,
is
for the
significant.
patient, it is.
Are there any other common conditions which you deal with? Do STIs or sexually transmitted diseases form a common part of your practice? Or
It does, but just going back to dyspareunia, there are, a dear friend is a dermatologist, and he always tells me 6,000 skin diseases, 26 sexually transmitted diseases.
Yes, yeah.
And to be aware that there's a lot of skin conditions.
which may affect the genitalia,
Yeah.
even though they're not sexually transmitted. So sometimes the person may think,
lichen sclerosis, lichen planus,
Yes.
chronic, and then
So and then obviously, because it's in a sensitive area, people are hesitant to seek care for it.
yeah, and then women sometimes are the cause of their own problems because they like to wash,
Right.
and they wash.
So what
And-
should they do?
Well, the wash we must all wash, but it's what we wash with, because it is just skin like the rest of your body.
Yes.
And so some women overwash,
Right.
and they buy all sorts of chemicals to wash. So we
You
you know,
change the bacterial sort of composition
yeah,
of the
the-
vulva and vagina,
Yeah.
and that may lead to thrush and other issues like that.
And so very often anything that's in the pelvic area is almost automatically seen as an STI.
Yes.
People think, oh, what did I do?
Right.
And as we know, thrush can be very common after antibiotics, diabetes, so many
Yes.
other reasons why women can have thrush.
Absolutely.
But again, women feel, how do I tell somebody? I feel dirty, I feel ashamed, all of these things, and they don't want to tell.
Yes,
And it's
yes.
almost like it starts from granny. Granny says, don't go there, don't touch, don't speak. And I always call men's genitals publics as opposed to women with privates.
Yes.
Because men will pick up much quicker if something is wrong with them
Yes.
versus women, because we can't see it, we tend to just ignore
But I mean,
it.
I think also the place that women are sometimes given in society may mean that they're less hesitant, they're less likely to talk up about something. They may be seen as that they're doing something wrong, and that's an area that they shouldn't really be interested in. Whereas men, on the other hand, sometimes will boast about their exploits and things like that. That's a whole
Yeah.
different topic for another day. But maybe we can move a bit on into men's issues. I'm sure you see some men's issues as well.
I do, yes.
Yeah.
So I see quite young men, and then up to older men. Though I don't know what in South Africa if we start testing men too late for prostate,
Right.
because a lot of the research are often American, European,
Yes.
but in Africa we see quite an aggressive prostate cancer in men.
Earlier,
Yeah,
especially.
earlier, because I see quite young men young, in their late 40s,
40s,
maybe,
yeah.
who has got stage 3 prostate cancer.
Yes.
Now, the stigma around a rectal examination, oi, oi, oi.
It's terrible.
And I just wish if we can get some spokesperson
Yes.
who just stands up and says, you know, we can
Well,
do
I'll stand up for it. I
Because-
think obviously we've advocated before on the show, but as part of screening, you
Yes.
need to do a PSA
Okay.
as well as a digital rectal examination, especially probably in the younger individuals where, especially if it's cancerous, sometimes the PSA starts going up a bit
Yeah.
later.
Because we have November,
Yes.
and it's sort of, you know, we make the awareness, but if you think the awareness we do around female cancers and breast cancer, and we go to cricket and it's pink
Pink, yeah.
everywhere, and then we sort of have November.
But we
and
need a
there's-
cute color for men. Unfortunately, we don't have a color which is quite as cute as pink for men. But I think we'll get back to Prof. Mcintosh after a little short break. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome back to Health Matters. We've been talking sexology and issues around sexual health with Professor Elna Mcintosh. You can see just the thought of sex gets my tongue all tied up, and
No, be calm. Deep
Thanks,
breathe.
Prof. Anyway, so we were discussing some of the men's health issues. We spoke about cancer of the prostate, but obviously there are men's sexual health issues which often come to the fore. Sometimes men are more likely to seek care. Sometimes it's, you know, an ego issue or whatnot, or sometimes they feel the woman is not important in the relationship, and it doesn't matter if they have, for example, premature ejaculation and so forth. How often do you come across these
See
issues?
so many young men with what we call performance anxiety.
Right,
I
right.
call it the frightened penis, because there's so much pressure. You know, again, back to social media.
Yes.
Everything, this poor
Everything
man.
must look like it did in the movies.
Yes.
Yes.
So a lot of young men, just like, you know, he's just a self-sensitive creature, and now he's
Yes.
got a new girlfriend, or we see, I call them the AIDS era kids. They were born in the era of HIV.
Right.
So they are young millennials. When they went to school, it was about the plaster and blood, and then it was about you're going to become HIV positive, and
right.
then they go to university and they meet me, and I'm bringing condoms, but they're petrified. Because
Right.
anybody can develop a fear, and it can get to phobia stage.
And how does it manifest in their
So
relationships?
they will lose their erection because
Okay.
they don't actually have a erectile dysfunction because of diabetes or hypertension. They just have, it's a panic.
So usually the adrenaline surge or the catecholamines will
Yes.
mitigate against an erection.
Yeah.
You really need to be relaxed and
Yes.
sort of a parasympathetic surge to
And you
develop
try and
that.
explain them the physiology, because
Yes.
I'm like, you're your own biggest your own biggest problem. Because I say to them, if somebody's got a priapism, we actually inject
Adrenaline,
for that
or
adrenaline, and you
pseudoephedrine and so
yes,
forth.
and you are
yes.
pumping yourself with adrenaline.
Yes.
So that's one of the reasons. And then probably the most commonest reason is what we call rapid ejaculation
Right.
or premature ejaculation, which, if you really think of it, the whole animal kingdom has very fast, rapid sex, and then it's because it's for
Yes,
procreation.
yes.
But now we are going, no, there must be foreplay, it must go on forever. And
Well,
so,
I mean, this is obviously to increase the pleasurable aspect of
Yeah.
sex for both partners.
so for a lot of men, they have rapid ejaculation, and then they feel, oh, this was terrible, and then they don't talk about it, and then that's it.
Right, right.
But whereas some men, that is what will happen, but they will have the refractory, the recovery period, and so the next, and it's a very South African
Yes.
term, but they speak of rounds.
Yeah.
So the next round would be better. But did we mention it's an adult show this evening?
No,
and the
we didn't.
children.
But the show is late anyway.
The children must be in bed.
Okay, so the children should be in bed for
Bed.
this next segment.
Yes.
Okay.
I'm just suddenly thinking of the children. But if you think of how we raise children, and sometimes that is where the problem starts.
Yes.
Most people don't give the birds and the bees talk. I call it the vulture and the hornets.
Okay.
And so a lot
So maybe the children
yeah.
should be awake actually, so that they understand. And I agree with you. I think it's a problem across lots of societies. It's the Muslim community is not unique in terms of broaching the topic with your children. You almost need to be friendly with your children and be able to talk with them, and for them, and sometimes the kid feels more uncomfortable than the parent. Yeah.
And my old professor, and I'm an old one now, she used to say, because I'd say, but when must we teach them? And then she said, if you haven't by 8, it is too late. And
Right.
not meaning, she talks about age appropriate.
Right.
Because most children by 8 now, if you're driving in the car, the headlines, it's everywhere.
So they know a lot of stuff.
They
But
read
you
a lot
haven't
of things.
controlled that.
And if we don't, and we are still, the parent is still the principal, I think, when it comes to sex
Educator.
education, that is, we mustn't leave it for the schools.
Yes.
And
I
of
agree
course,
there.
if your child is being abused, how
Yes.
will the child know the difference between what is right and what is wrong?
Yes.
And
Well, I think what may be a useful, it is almost counterintuitive, but what may be a useful way to approach your children is from the context of prevention of disease, because it's
Yeah.
almost approaching it from a clinical context, so that they understand that you're not trying to mold their behavior directly, that you're concerned about them. And I think sometimes we've seen that approach work, but it's obviously, I think you need to have a relationship with your kids, which
there's
allows
also
you to do
great
that.
books, and I think we should start early, where we can talk about the cat had kittens.
Right.
That
Where did those kittens come from?
and just like a reproduction,
Right.
and go and take out all those early scans, and dad put the egg in mommy.
Yes,
Oh,
yes.
the dad didn't put the egg. Mommy brought the egg. Dad brought the fish. You know how they teach you? in
Yes,
school?
yes.
It's all about the egg.
Yes. Well,
and
normally in school they start with a flower. It's just easier.
flowers and the bees.
Yes.
But it is important, and
Yes.
and parents, it is that difficult, because nowadays, if you think of young girls, they start menstruating at age 9.
Sure. Yeah.
And we actually, not all of them, but you sort of have to
Some
be
may, yeah.
prepared, because you don't want her to feel embarrassed, or that a lot is around shock and horror, and nobody told me about this.
Yes.
And
So I think, from the Islamic perspective, there is a system of madrasa or Islamic school where some of these things are addressed from a sort of Islamic perspective, and almost indirectly brought in. But I think that doesn't absolve parents of their role as primary educators and caregivers, because the context may be different from the children in terms of how they're picking it up from an Islamic perspective, or how they may be picking it up from school, and they may not directly link it to how it behaviorally needs to, be part of their life. How they need to understand that there's a natural part of their life and where it should fit in their life. Obviously, from an Islamic perspective, the emphasis is on religion on sexual intercourse within the confines of a marital relationship, and to save oneself for marriage, and abstinence is a big part of that. So I think that's another issue which parents sometimes have difficulty broaching with their kids.
Because we're competing with, if you look at all the information out there, and we try and control our kids, and they must have little airtime, they must not spend too much time on the cell phones, but there's just
sometimes the more you tell somebody not to do something, the more they want to do it. So
and if we have to, because it's sometimes easy for me to go, oh, this is fake news, because we know things. But how do young people know what is fake and
there's
what
no
is
filter for them.
What is real?
The filter of experience has not been built up yet.
But for me, that family unit is so important.
Yes. Do you often consult couples as a group together, or would you say that the majority of patients would come as individuals?
So for me, the couple, the relationship is my patient.
Right.
So often I will say the woman with vaginismus, she is sent to me, and we almost go like, oh, she's the problem. But the husband needs to understand.
So the problem is the family's problem.
It's a couple's problem. He needs to understand. We can't just fix this overnight.
Yes.
It takes a while. And so whilst he doesn't have to come for every session,
Right.
but often, and the longer they've waited, the dynamics become,
And obviously, I think because of that, because sometimes you can't sort out the problem without both parties being present, it's difficult to get everybody onto the table together. Maybe the husband doesn't see that, especially, I think, premature ejaculation. Sometimes the husband may not see it,
and the
or the wife may not see it as such an important issue. We just live around that issue, and structure our lives around it. It's not going to be important to us, and for others, it may be important for the wife, and not important for the husband, or vice versa.
I call it my 4 T's.
Yes.
And they stand for time and trust and talk and touch.
Yes.
And so just like we've made the time today to talk,
Yes.
I encourage, you need to actually sit and address the problem. Because
Yes.
we're good at lifting the carpet and putting all under, and then the Swiss Alps comes flying out one day.
Yes,
You know, they
sure.
speak about. So make time. So that's why I encourage things like date night, or because young couples, sure, they have no time, and then talk. And often we don't always have the words, or it's
Yeah.
difficult because we grew up differently.
Yes, yes.
And trust. If trust has been broken, if there's been infidelity, it is really,
Right,
really
yeah,
hard to
that's a
fix
big
that.
issue. That's a big issue.
Because
Yeah.
women will say, I can forgive, but I'm not going to forget. And sometimes let's move on. And
Yes.
sometimes I even get pastoral or whatever the religion is, sometimes we work on that. And the last one
Yeah.
is touch.
Right,
Our
right.
biggest sex organ is our skin.
Sure.
If we're really angry, we say, don't touch me.
Yes,
And the woman will
absolutely.
put the no touch signal that
Yeah.
hey, don't come near me. So loss of libido, often we can't just blame her contraceptive. Sometimes she's just angry,
Absolutely, yeah.
and so to
Or
address
tired,
those,
or not getting enough rest, not getting enough sleep, children, there's many other issues. I mean, just the final issue, Prof. One of the things which I find which has led to a loss of some of these issues being discussed is that breakdown in the relationship between families and their general practitioner. They don't often have a trusted general practitioner. As you say, they go straight to Dr. Google
yes,
or Facebook and social media. And sometimes, I mean, I see it myself, many patients will contact you directly as a specialist because they read something on the internet, and sometimes it's not appropriate for you to be seeing them. It's a waste of their money,
yeah.
and you're going to over investigate. And sometimes they just needed to start off with a GP. What would you say about that?
The role of the GP is incredibly important because just what you've said.
Yes.
People can't always afford to see a specialist. And for me, I think the GP knows his patient. If his patient is on blood pressure and he's a diabetic, part of this conversation is, and how is your sex life?
Yes, yes.
Even if you
absolutely.
haven't addressed it, because we know.
Patients may be shy to tell you, but
Yeah.
if you ask them and you've got that relationship, it
Yeah.
may make a big difference.
And for women, sometimes you might be in Blikkisdorp and there's one doctor and he happens to be a man. And it is important that there's a chaperone, all those rules or
Yes,
ethical
so that you
things
trust the person.
that goes with it. But that would always, for me, be your first port of call is your GP who knows you, who looks at all the other things before we actually jump. And Google, Google. Google is a guide, but Google is not
Not the doctor.
not the doctor.
Prof, thank you so much. We've run out
Thank
of
you.
time with this session, but we're going to link into Dr. Shaheda Umar with the next session, and she'll be coming up soon.
Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters. Today is a very special occasion, a very special day on Health Matters. It is the 38th Islamic Medical Association Convention. And our special guest here today with us is a legal expert, Ms. Candice Pillay. Welcome to Ms. Candice
you.
Pillay. And we are going to be focusing on behind closed doors, breaking the silence behind closed doors, a topic that very many people would frown upon, would turn away from, and pretend that it doesn't exist. It's about child abuse and more specifically sexual abuse of children. Now we know that 1 in 4 girls are victims of abuse under the age of 10, and 1 in 7 boys are victims of sexual abuse under the age of 10. And it may sound like it's not too many, but 1 child is 1 too many. There are many concerns around the fact that a lot of children who come forward and make disclosures are often turned away, are threatened, or often subjected to some level of coercion. And as a result, children recant, withdraw their disclosures, and therefore we've got Ms. Candice Pillay now speaking to the issues around legislation, the rights and responsibilities. And I'm going to hand over to Candice.
Thank you, Shaheda. You know, one of the most important things that I find is people don't understand the law. And first and foremost, we start with the Constitution, which is, you know, the supreme law of our land. And you'll be surprised how many people don't read the Constitution or even the Bill of Rights. And that's very important when it comes to children because Section 28 actually sets out, captures what a child is entitled to and the rights that a child has to certain protections. So that right is a constitutional right because it's been created in the Constitution. And of course, we know that where there is a constitutional right, it then gives rights to constitutional obligations. And then we have to look at who has these obligations to this child now. So, of course, the parents have obligations to care for a child, to look after the child, to give the child a name. But when parents or family members or society fails a child and a child is a victim of a sexual crime, then that obligation transfers to various members of state, to private individuals. And we find that these individuals actually do not know or are not aware that they have these obligations. So, for instance, um, the medical doctors, the speech therapists, the occupational therapists, the dentists, in fact, every health professional, every medical professional has a legal duty, a constitutional obligation, firstly, to report an incidence of child abuse. And then we see that the Children's Act actually expands on that in Section 110 and says, and it names each and every health professional and says, when a disclosure is made, there is a prescribed form that must be filled out, and that disclosure must be referred. It can be referred to another medical professional, it can be referred to the Department of Social Development, a social worker, and it can be referred to the South African Police Services for them to take the matter forward. Because at the end of the day, a failure to report is actually a criminal offense. And more than that, a failure to report can lead to damages being sought against the medical health professional.
So I like what you just said now. It's about that failure to report, that there are huge consequences,
Exactly.
that it's a legal obligation, it's mandatory, and there are stipulations and regulations in different pieces of legislation. As you said, the Children's Act, the Sexual Offences Act makes provision for that, and even our Constitution makes provision
Yes.
for that. However, we find that people are often afraid to report. And the reasons behind that is, if we find in the case of intrafamilial abuse, incest, for instance, the case study that we unpacked at the convention, where a mother often is afraid to go forward and would deny that, or would refrain her child from making that disclosure again. What is your response to that in terms of the legislation?
But see, legally, a crime has been committed. So there's an obligation on us all, whether we are in a profession that obliges us to report or not. We have to report. As a mother, if something happened in my home, I'm obliged to report it in any event.
But Candice, what if she's a victim of domestic violence? Is she justified because of the excessive fear, the fear of being slaughtered, murdered, brutalized?
So it is you're quite right, because the law is not clear cut. It's not black and white where you can say she has to and she can't. We have to be cognizant of the fact that people live in those circumstances. In our case study, you had a mother who had undergone years of emotional and verbal abuse, and while aware of this crime that was committed, actually colluded because of fear for her own safety. And perhaps part of that fear was fear for her child's safety, that once this was disclosed, then it would break the family apart, or they would be ostracized. This is clearly one of those situations where you need a holistic approach. You need social workers to come in and to work with the family in order for them to understand the social role that each one plays, but you need the police services to come in to handle the criminal elements of the crime that occurred. You need lawyers to come in and handle the legal implications. So you cannot go in with a clear-cut answer and say that in every situation the mother has to. The mother in many cases is the victim herself. What we are saying is that when legal obligations exist, if the mother discloses to a third party, if the disclosure happens, there's a whole team that surrounds that family to try and assist the family with what has just happened.
So something else that is also very, very prevalent is that there's often fear that what if my suspicion, you often find mothers will come forward and say, I suspect that my husband is sexually abusing my child, or a relative is abusing, but it's a suspicion, a hunch. It's not confirmed. What should a person do in those circumstances?
In those circumstances, we have to go to the experts. I think even myself, I'm not a doctor, I'm a lawyer, so I wouldn't know if there was sexual abuse or not, and I would have to rely on the expert. So organizations like the Teddy Bear Foundation, like your local GP, because your GP does have the legal duty to report, or your hospital or a social worker, is to go to them and make the disclosure. Because once you do, they know exactly how to then conduct the investigation so that the confidentiality is maintained, the integrity of the whole process is maintained. It doesn't explode in the family and break the family up, and people are upset and
the total
all of
disintegration.
Integration. They do it in a manner that also protects the victim, so that whatever comes out, even if it was a hunch and it was unfounded, there's no loss after that. People are educated and then they understand better. Okay, in this instance, I overreacted, and then they go with that information. But if it is then proven to be child abuse, then they know in that instance, I'm now empowered with this knowledge. It's not reckless knowledge, because I think at the Teddy Bear Foundation, it's information given with counseling and with a support structure. So you don't just walk out and say, yes, the child was raped and people must account for it. The individual goes out and says, I have now an obligation to handle this correctly, and to understand how this abuse is going to affect my family, my society, the child in the school context. So it is a lot of responsibility that goes into the counseling for even the disclosure.
Intervention.
Yeah.
So the next question is often the case that if I report and if there is no compelling evidence, will I, as the person reporting this abuse to the law enforcement agencies, and after the investigation they do not find anything conclusive, will I, as the person that has reported it, be subjected to any legal recourse, even though I have acted in good faith and pure goodwill, looking at the best interests of the child?
If it's malicious, of course. If you have been malicious, and we find that many times in acrimonious relationships, parties become malicious and they make all sorts of accusations, there will be repercussions, because they're false accusations. You've perjured yourself, etc., or you wasted the court's time or the police officer's time. But where there's been a legitimate concern, there are no repercussions. You've come forward and you've reported a suspicion, and the suspicion was then investigated. Remember, the court is the upper guardian of all minors, and so the court has the duty to look at what is in the best interest of minors. This is a test that is set out in Section 28 of the Constitution. It is expanded in the Children's Act to say we always act in the best interest of a child. And is it in the best interest of the child to remain silent? Or is it in the best interest of the child to make a disclosure and have it investigated by professionals who know what they're doing, and then have that responsibility to say, at least I did it, and I know I've confirmed for myself that there's nothing to worry about, and to go away with that knowledge. So I think when people are considering disclosure, there's never a good reason not to disclose. Even if you have a suspicion, the section 110 is very clear on the part of individuals who have a legal obligation to report. It's a two-part test. If you can conclude definitely that the child was raped or sexually assaulted, so for example, a doctor sees the child, there's bruising, there's bleeding, etc., you can conclude that's happened, you have to report. But if there's a suspicion, could just be on the part of a creche, the owner of a creche, or a teacher at school that looks at the behavioral changes in a child, they still have a legal duty to report it. So it doesn't matter whether you know for sure. In fact, you are supposed to care enough about the child to report anything that is
I
different.
think you raise a very important point, because at the Teddy Bear Foundation, we strongly propagate that we'd rather have adults, parents, people out there acting on a hunch instead of being laid back and complacent about the situation.
Exactly.
We'd rather have neurotic people, overly concerned than not being concerned and taking it for granted.
And even if it's not child abuse, social workers and psychologists are trained to find out what the problem is. There may be other problems that the child is experiencing that will be brought to the fore.
And yeah, I think on that note, just to remind everybody out there that child abuse should be everybody's business. And together we can work, if we work together, we can make a meaningful difference in the lives of all children in terms of their protection and safety. Assalamu alaikum wa rahmatullahi wa barakatuh. Just to remind the viewers that have tuned in, this is the 38th IMA Convention, and our guest today here at the Wanderers is a legal expert in the field of child sexual abuse, Ms. Candice Pillay. Ms. Candice Pillay has been part of the panelists on Behind Closed Doors, Breaking the Silence, and the focus is on child sexual abuse. Candice, the case study that was presented, we had two victims. One, an adult who was a victim of incest as a 10-year-old, 11-year-old, and she had a baby at the age of 12. And 9 years after the fact, she came back with another disclosure, not just about her incestuous relationship, but her concern was for a younger cousin who was the very tender age when she was a victim of sexual abuse by the same alleged perpetrator. Now, in terms of the legislation, we know previously there was statute of limitations, there was a prescription, a time period. Perhaps you can speak to that and elaborate on the challenges that existed and the current situation.
So there have been a number of developments in our law since then. Now, previously, for very serious offences, there was no prescription, which is what we call it in our South African jurisdiction, but known as the statute of limitations in the US. A time period is allowed for you to bring a case or report a case. And in South Africa, for very serious offences, there was no prescription period. But for sexual offences, the prescription period was 20 years. And this was then challenged quite recently by the Levenstein case that went to court. And the Teddy Bear Foundation was actually instrumental in that. And what had happened with the Levenstein children is that when they were very young, their parents would leave them at a friend's home for them to ride horses. And after they would ride horses and play, the friend would then allow them to go swimming and then would join them in the pool and touch them inappropriately and had then committed various acts with them over a period of years. as the children grew up, they never spoke of the incident. They grew up, and as adults, encountered various emotional problems, relationship problems, and decided to come forward and disclose. But of course, more than 20 years had gone by since the alleged offences had occurred.
And they were not in a position to open a criminal case
Yes,
then.
and that's exactly what the court, the case went about, because when they went to open up a criminal case against the perpetrator, they were told it's more than 20 years. Any case you have or offense has prescribed. You cannot bring your case any longer. And this is where the Teddy Bear Foundation was instrumental in influencing the courts to change that provision so that it is now unlimited. So any sexual
At any
offense,
point or period in life.
exactly. So it never prescribes. There's no end to it. If you wake up one day and you're 50 and you remember, or you are confident enough to come forward to speak about a crime that was committed when you were a child, you are entitled. That is your right. So that's been quite amazing for an advancement and progress for our sexual offences. A few other changes that have come about is, in the past, women were not allowed to give evidence by themselves in our courts in cases of rape. Now, of course, the courts would say you need someone to corroborate it.
Yeah, not
but
a single witness.
single witness rule. But when you are being raped, there generally is not a witness. There's just the victim and the perpetrator. And that was changed in our law to say actually a single witness can give evidence, and there's no caution to be applied to that, because you don't need the corroboration. And what is required then is a very good trail of evidence. And we tell victims of sexual violence that if the physical evidence is not available, there's always the narrative, the version that the victim has that is factual, of the dates, the times, the number of incidences, the methodology of the incidences, because some perpetrators have an MO that they would use. There's also the expert evidence that comes from medical doctors, from a psychological, medical, legal examiner.
Psychological, yes.
And it's a forensic exam, because it really looks at the person now and tries to unpack their behavior through the narrative to either confirm or dismiss that the incidents did actually happen. So there is a lot more that we have available to us now that we can actually present in court as evidence.
So coming back to that case study, of course, looking at both the adults now and the child. So the adult would certainly have recourse to legal action. There would be no prescription on time period. You know, it's so many years after the fact, but you would certainly be given the opportunity to lay a charge after so many years. And of course, for the younger victim, also, as you've highlighted so clearly and concisely, the investigation and all other processes that need to be followed in order to ensure that the best interests of the child are met.
Yes. And in terms of both the older victim and the younger one, there's a whole body of knowledge now that's been developed in psychology that even speaks to the experiences that they went through of telling a story, recanting for fear of ostracization in your community, or because family members have said you're breaking the family apart, or how can we say this is an influential person, etc. And people normally recant and they say, no, this didn't happen, I fell down the stair, or something else happened, it was a stranger that did it. And the law actually recognizes, in terms of the psychological evidence, the normal reaction of a victim to make a statement and then retract the statement because of that fear. So people who do it now, it is not even relied upon in the rules of evidence to say you made a statement, you withdrew the statement, you made a second statement. What is looked at is consistently what have you said, and that is then tested in court, and it is up to the magistrate then to understand why the version put forward of abuse was recanted and then brought forward again.
But I think you're raising something very important here, because often if we look at law enforcement agencies and the criminal justice system within the courts, when a victim changes her story, and I think what you are saying is that is what is actually normal, because there will be discrepancies, there will be fragmentation of information, there will be your typical empty sandwich syndrome where we'll get peripheral details on either end, and there'll be a lot of information missing in the middle, a chunk of information. And that's all part of this victim and sexual abuse process. The other thing I think we also need to make the viewers more aware of is the fact that victims often will deny, or like you said, change the story, a totally implausible explanation. A child will say, if a child is bleeding from the genitalia, that she fell off her bicycle, she fell off the horse, or she fell onto a branch and that injured her. And I think those are the things that we have to take cognizance of, but using expertise as you have so aptly described, that there are experts and to utilize the multidisciplinary approach.
And medicine has become so advanced. It's taught lawyers that things are not straightforward. When we look at the sort of the world of psychology, we now understand what post-traumatic stress disorder is. We now understand how trauma affects the disclosures or the remembering factual evidence, that you will remember some facts the first time you recount the story, that you'll remember more the second time, that you'll remember even more the third time. And in understanding that that is how the brain deals with trauma, the rules of evidence also allows for the fact that, okay, we have to understand that trauma has dulled the senses to not remember everything. And so they allow for subsequent versions to be put forward and to be tested.
And you've touched on something so important about trauma and the effects and impact on the brain. Because what does trauma do? It puts one into a fight,
or
flight, or freeze mode.
Yes.
And often victims will start suppressing, numbing themselves, dissociating themselves from the traumatic event. It's all about protecting themselves. So that is why we would find some victims not being able to recall everything or narrate things clearly and coherently. But I think we're coming to the end of the show, and I would like to just leave the viewers with a few take-home messages, parting words to the viewers. What would you like to leave the viewers with?
I think for me the most important thing is to understand that we have a legal obligation to care for our children. It's not just our child. Every child is our child, and in a society that doesn't care for its children is really growing a society that's not going to care for the future. And so the obligation is on every one of us, not just me looking after my child, but me caring for the child that walked into my office that says that this bad thing happened to me, help me. So as a lawyer working in this field, I have a lot of compassion for children, but I also know that they need me to fight for them, just like that they need the GP to fill out the form, and they need the social worker to fight for them, and they need medical experts. They need people to stand up and be the voice for them. And I know the Teddy Bear Foundation also always says we are the voice to the voiceless. And in much the same way, that's what I would like to leave with the viewers, is that raising a child, it takes a village to raise a child. You've reminded me of that, Shaheda, many times, is that it is all our obligation. You know, not just the parent of the child, but in many cases, it is the parent that actually hurts the child.
And I think on that note, we need to end on the obligation.
Yes.
Where we are entrusted with that responsibility of ensuring the safety and protection of each and every child, regardless of who that child belongs to. That child is a part of the whole. And I think we need to realize that if we do not stop it now, evil will continue to prosper. where no action is taken.
When you look back, will you be proud of your actions or would you regret it? And I think many people, almost every person who did not report or withdrew when they did disclose, regrets that they have done it. But the ones who've been brave actually look back without regret and said, I'm glad I actually did this.
And I think there should be collective vision around the protection of children at all times. On that note, we will end here, but also to thank Ms. Candice Pillay for her knowledgeable dissemination of experiences on the ground in terms of the legal obligations. And I'm sure the viewers will agree that it was definitely enlightening and informative. We will end here. Assalamu alaikum wa rahmatullahi wa barakatuh. And a verse from the Holy Quran. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Wal asri innal insana lafi khusr illa alladhina amanu wa amilus solihati wa tawasaw bil haqq wa tawasaw bis sabr. Sadaqallahul azim. Until health matters next time.